choice of antihypertensives. There is a very wide range of antihypertensive drugs available today, and the choice will depend on the tolerance of the patient to the drug, that is, how the patient responds, and the side effect, the individual choice of the doctor and the cost of the therapy, what the patient can afford. In a middle-aged hypertensive patient, beta blockers are the first-line drugs, unless specific indication exists for other drugs, starting with a beta blocker, tabatin, atenolol 25 mg per day up to greater than 100 mg BD, tablopressor, metoprolol 50 mg per day up to greater than 100 mg BD, tabcardilas or carvedilol 6.25 mg BD up to greater than 25 mg BD preferred in young patients. Beta blockers are the drug of choice in hypertensives with angina and tachycardia or tachyarrhythmias. These are time-tested drugs that reduce cardiac mortality, especially in sudden deaths due to arrhythmias. Problem number 1. But some patients do not tolerate beta blockers well and experience either frank bronchospasm with wheezing and rhonchi or complaining of low-grade dry cough. In either case, an alternative drug has to be prescribed, preferably a calcium channel blocker. If a beta blocker is essential, due to IHD, then give tablet Durafilin 1-3 tabs per day to control the bronchospasm. But if it is not controlled, then beta blocker has to be stopped and calcium channel blockers and other coronary vasodilators should be prescribed. Problem number 2. Hypertension is severe, and it may not be controlled with the highest dose of the drug. It is not advisable to prescribe the highest recommended dose. Rather, combine it with another drug, either a calcium channel blocker or an ACE inhibitor. If there is edema or obesity, combine with hydrochlorothiazide, example, diabeta, or just change the drug. Problem number 3. Beta blockers may increase intermittent claudications and PVD. In diabetics, the dose of oral drugs may have to be adjusted. In an elderly patient, if there is evidence of ventricular hypertrophy or CCF, then start with an ACE inhibitor, then add a thiazide diuretic, the beta blocker, or the alpha blocker. If the patient is a diabetic, then start with an ACE inhibitor. They improve glucose metabolism and prevent nephropathy. If not controlled, add a thiazide diuretic, then an alpha blocker or calcium channel blocker. If he has anginal symptoms, then start with a beta blocker or calcium channel blocker. If the patient has cough, asthma, or emphysema, then a calcium channel blocker would be the best drug. If urine shows albumin, that is, evidence of renal dysfunction, an ACE inhibitor is the drug of choice. If the patient has prostatic symptoms, then the drug of choice is an alpha blocker, starting with an ACE inhibitor. Tab-Invaz or enalapril 2.5 mg OD up to greater than 10 mg BD. Tab-Ramase or Ramipril 1.25 mg OD up to greater than 10 mg OD. Tab-Listril or Lisinopril 2.5 mg OD up to greater than 20 mg OD. Problem number 1. Many patients experience dry cough with ACE inhibitors. Change to calcium channel blocker or alpha blocker would be ideal. You may try selective angiotensin I blocker, which shows a much less incidence of cough. Example, Tab-Losgard or Losartan 25 mg OD up to greater than 50 mg 2 OD. Problem number 2. The BP is not controlled, then add a beta blocker or a calcium channel blocker, or change to another drug. Problem number 3. The patient is well controlled on another drug, but has CCF or LVH. Then add a small dose of ACE inhibitor, that is, Tab-Invaz, enalapril 2.5 mg odd or Tab-Ramase or Ramipril 1.25 mg odd or Tab-Listril or Lisinopril 2.5 mg odd. If the patient is asthmatic, then a calcium channel blocker will be the drug of choice to start with. Starting with a calcium channel blocker. Tabdipin, Nifedipine 5 mg OD TDS up to greater than 20 mg BD. A retard tablet will be better tolerated. Tab-Amlagard, Amlodipine 5 mg OD up to greater than 10 mg OD. Tab-Felagard, Felidipine 5 mg OD up to greater than 20 mg OD. Problem number 1. The BP is not controlled, then add a diuretic. If necessary, add an alpha blocker. In non-asthmatics, any other drugs may be added. Problem number 2. Some patients experience severe headaches or giddiness with calcium channel blockers. In this case, the drug has to be changed. Starting with losartan. Tab Losar 25 mg OD in morning, 50 mg OD greater than Tab Losar H. OD greater than add Tab Losar 50 mg HS greater than add amlodipine 5 mg or metoprolol 50 mg OD to BD. Some clinical problems. If on routine checkup you find a BP above 220 systolic or 120 diastolic, the patient should be put on immediate bed rest. Puncture a capsule of nifedipine 10 mg from your emergency bag and squeeze its contents under the patient's tongue. Give an injection of composed 10 mg Amstat or orally diazepam or alprazolam. Check BP every 10 minutes, and repeat sublingual nifedipine SOS after 10 to 15 minutes, till BP comes to an acceptable range, that is, below 180/110. Refer the patient at the earliest to a physician for further advice. BP fluctuates and the dose cannot be fixed. Is it a pheochromocytoma? Does the patient have attacks of headache, palpitations, sweating? Ask for ultrasonography of adrenal glands, urinary catecholamine studies, and refer to a physician. If hypertension is detected in a young patient. If the patient is around 30-35 years, ask whether his father, uncle, or brothers have hypertension, because essential hypertension appears early in the Indian population. But if there is no family history or the patient is younger than that, definitely refer him to a physician to rule out secondary hypertension. If only systolic BP is high, treat first with a diuretic. If not controlled, add a beta blocker or calcium antagonist. Example: 1. Tab Biduret, 1 OD in the morning. 2. Tab 8 and 50 mg OD, or Tabdipin 10 mg OD. If the patient has had long-standing hypertension for more than 10 years, then what would you look for? This patient is a high-risk patient and must be properly investigated and treated. 1. Check lipid profile, and if it is abnormal, that is high cholesterol, LDL, triglycerides, or low HDL, then treat accordingly. 2. If the patient has anginal symptoms, suggest a stress test and if necessary coronary angiography. 3. Check urine for microalbuminuria. 4. Get ECG and echocardiography. If the patient has an abnormal lipid profile. Beta blockers have adverse effects on lipid metabolism. ACE inhibitors or alpha blockers are the drugs of choice. Tabcardase 2 to 5 mg BD, ramipril, or tabhytrin 1 to 5 mg OD, terazosin. Drugs are used commonly for uncomplicated hypertension. 1. Telmisartan 20 to 40 mg OD. 2. Losartan 20 to 50 mg OD. 3. Metoprolol 20 to 50 mg OD or BD. 4. Amlodipine 5 to 10 mg OD or BD. 5. Atenolol 20 to 50 mg OD or BD. 6. Diter plus OD diuretic.